starting to talk about pain modulation and pain control, of course, the focus in this class is going to be using physical agents to control pain. But I'm going to introduce an idea that's called the pain matrix. And the pain matrix is basically several different systems in our brain that contribute to the control of pain and the output of pain from our brain. So the pain matrix involves sensory, motor, and limbic systems of the brain. Limbic systems are sometimes also called primitive or emotional systems. And the pain matrix produces three distinct outputs. One of it is conscious perception of pain. So a lot of that happens in the sensory thalamus. In order to be conscious of pain, the pain has to travel to the thalamus. And so the sensory tracts, a lot of them end in the thalamus. And so we get that conscious perception of pain. The physical action and motor responses happen in the motor system. And the activation of the homeostatic systems happens in the limbic systems of the brain. So homeostatic systems, the sympathetic nervous system is the fight or flight response. So when the sympathetic nervous system is activated, boom, it's all activated at once. So it's like 0 to 100. Your heart's beating faster, your pupils are dilating, you're getting ready for your fight or flight. So that's kind of your stress response, your sympathetic nervous system. So if you have sympathetic influences that can increase your anxiety, increase your distractibility, increase your pain. So really all of those things are going to contribute to our sensations of pain. So we've talked about types of pain in pathophysiology. Acute pain is the direct result of actual or potential tissue injury due to a wound, disease, or invasive procedure. Acute pain is usually expected to resolve within 3 to 6 months, depending on the pathology. Acute pain is usually easy to localize and easy to describe. Chronic pain is enduring or recurrent pain. It persists longer than typical for a condition, and it could be associated with an intermittent or chronic disease. Sometimes chronic pain results from an inadequate response to appropriate and or invasive care. So that could be like your endogenous opioid system's not working. That's your inadequate response. Chronic pain can significantly impair functional status. So chronic pain can be something that really kind of ruins your life. We don't want to get to that point. And in contrast to acute pain, which is easily localized, a lot of times chronic pain is diffuse and sometimes even seems like it's spreading. It really isn't. It's an effect of the nervous system, and it affects people's mental status. It affects people's social status. So chronic pain can be a real problem. Referred pain is pain that's felt at a location distant from its source. It can be diffuse and variable in distribution and character. So a lot of times referred pain is referred visceral pain. So we've got some visceral organs that are referring pain to a surface structure, so we can be aware of it, because you don't really feel pain in your heart or in your liver. You feel it usually referred to another location. And it can be pretty specifically mapped in the body, and we'll look at a referred pain chart in a minute. Radicular pain is also felt at a location distant from its source, but it's generally located in a specific neural distribution. And it's generally associated with other deficits such as sensory or motor losses. So when people have sciatic pain where it radiates from their lumbar and sacral nerve roots down the back of their leg, that's radicular pain. So it's located in the sciatic nerve distribution, and it can be associated with sensory and motor losses in that distribution. So this is the referred pain map from the book. Heart pain can be, neck and throat, can be right in your chest or in your left arm or upper back. Gallbladder pain can be in your right shoulder or your right upper quadrant going around to the back. And ureter pain can be interpreted as flank pain. So it's really our organ system, our visceral organs are synapsing with sensory nerves, and they're showing up on the surface of the body. So because it can be mapped so easily, a lot of times people can, doctors and physical therapists can interpret referred pain as to what's really going on with the person, which is kind of interesting. So we have lots of different ways of assessing pain. There's the classic, what's your pain from 1 to 10, blah, blah, blah. And those are usually numeric scales. Comparison with a predefined stimulus. So a lot of times we'll say to patients, could you give me what your pain level is from 1 to 10, 1 being very low and 10 being emergency room pain or the worst pain you can imagine. So that's comparison with a predefined stimulus. Semantic differential scales are wordless or categories to describe pain. So there's one that's I'll introduce you to that's called the Mankowski pain scale. And it has the 1 to 10 scale, but it qualifies it. So it says like, oh, at a certain level, you can do most tasks, but the pain creeps into your consciousness every now and then. And it's easily treated with over-the-counter pain medication. Or you have constant pain, but you can still do all your functional tasks and you need stronger medication to treat it. Or medication doesn't touch it, it keeps you from doing functional tasks. So using the words and lists, it can be a more exact way to differentiate pain. Other measures can be daily activity and pain logs. A lot of times people with chronic pain, we will ask them to keep those pain logs so they can kind of make some connections between what may cause their pain to go up or down. Body diagrams where people draw in their pain. A lot of times intake paperwork at a clinic includes a body diagram. Open-ended structured interviews. So that's like your physical therapy initial evaluation where they're asking like, does anything make your pain feel better? Does any position relieve it? Does any activity relieve it? That sort of thing. And then physical examination and testing. So that includes sensory and neurological testing and muscle testing. So this is like a visual analog scale. You put an X on the line to indicate how severe your pain is. The faces scale, like nothing, hurts a little bit, hurts a lot, that sort of thing. Sometimes they'll use that with little kids. This is a really detailed scale that you actually qualify the types of your pain. So it's flickering, it's tugging, it's pulling, it's hot, it's burning, it's, you can read all the words on there. I'm not going to read them to you, but a lot of doctors will use something like this to try to classify somebody's pain. There are also the things like the Mankowski pain scale where it gives you an activity that's possible with the individual pain and what type of medication relieves it. This is the body diagram where you tell them draw in where it hurts. Sometimes you'll get people where they're all drawn in, like they just all over the body. So that's kind of not very helpful, but you often see that in intake paperwork at a physical therapy clinic. So for pain management, the goals of care, whether it's medical or physical therapy care or surgical care, a lot of times the main goal is to resolve the underlying pathology when possible. So usually with surgery, that's that's the approach that you take. Modifying discomfort and suffering, you can use physical or medical treatments to do that, and surgical. Maximizing function within the limitations imposed by the patient's condition. Yes, that's what we really focus on in physical therapy. Persistent pain may need integrated multidisciplinary treatment. So that includes psychological and physiological therapies, physical agents, and exercise. Exercise is a great pain management tool. So that is a tool that we have in our toolkit for physical therapy. So our physical approaches to pain management include physical agents. The benefits of using a physical agent are that physical agents can directly moderate inflammation. They can modify pain transmission at the spinal cord with the gate effect. They can alter nerve conduction, so ice and heat. And they can also increase endorphins. So you can have ascending and descending pain control with physical agents. Some physical agents may also help to resolve the underlying cause. So soft tissue mobilization can help increase circulation and can help move fluids. If swelling is the underlying cause for your pain, manual therapy can help. It allows patients, physical agents allow patients to interact with their injured body parts and practice independent pain management skills. So that is super important. And physical agents avoid medication-related side effects. So yay, that's really good. So the common types that are used in therapy, and we're going to do all of these this quarter: cryotherapy, which is cold, thermotherapy, heat, electrical stimulation, traction, not on this list, soft tissue mobilization. Pharmacological approaches can be systemic analgesics, including non-steroidal anti-inflammatory drugs, acetaminophen, which is Tylenol, opioids, anticonvulsants, which usually are described as muscle relaxers, and antidepressants are often used for management of pain as well. Spinal analgesia can be used, so it's like a spinal cord injection, local injection, like a cortisone shot. I was dealing with plantar fasciitis last year, and I had a cortisone shot in the bottom of my foot. Super painful, but it did help. And topical analgesics, like my favorite, Icy Hot, works really well, or BioFreeze, Icy Hot, all those topical analgesics, or things like lidocaine. That's another topical analgesic. Medication side effects can be a real detriment to using medications. So opioids can have icky side effects. Common side effects of them include nausea, vomiting, sedation. So somebody's just gorked on their pain meds. Gastrointestinal slowing. That's why people aren't hungry when they're on those medications. And respiratory suppression. So that's huge. That's a bad side effect. Respiratory suppression can be dangerous. And tolerance, dependence, and addiction can be a dangerous side effect of opioid drugs too. So, hey, wouldn't it be great if we had some other treatment that we could use and not have to use those? So, physiological and psychological approaches to managing pain. Exercise is a huge component of pain management. If you raise your heart rate just 20 beats above your resting heart rate, it does not take much effort to do that. It can help manage your pain. Selecting appropriate exercises for patients with chronic pain can be challenging, but if you start at a lower level and gradually increase intensity, it can be super, super helpful for them. Cognitive behavioral therapy can help patients cope with pain and perceive their pain as manageable. And the kind of things that they do in cognitive behavioral therapy are pacing, attention diversion, cognitive restructuring, graded exposure, and goal setting. So all of those can be helpful in managing pain. Comprehensive pain management programs are often based on a biopsychosocial model. The focus is not on eliminating the pain, but on independence and overall quality of life. And it's a coordinated team approach. So interventions can include medication adjustments, graded therapeutic exercise, and functional rehabilitation. That's what we do in physical therapy. Occupational therapy also, pain neuroscience education, we do that in physical therapy as well, and cognitive behavioral therapy. So multidisciplinary approach can be very successful for people with chronic pain.